Evening all. My name's Dan Bausch. I'm a faculty member here at the school. It also leads something called the UK Public Health Rapid Support Team. I'll tell you a little bit more about that later in the evening. But this really came out of a meeting that our director Peter Piot called last week, and to assemble a small task force for the coronavirus outbreak that everyone's paying attention to. And so part of those activities, in addition to figuring out how the school responds to this outbreak and also looks for opportunities and contributions for research and capacity building, we thought it'd be important at this point just to get together relatively informally and give you the biggest or the latest update from experts, if you will. And so we have a nice panel, I think, tonight. So first, Martin Hibbard. All the speakers are just going to speak for 5-10 minutes like that, so I'm putting some pressure there on so 5 to 10 minutes, Martin will go over some of the basic virology and then some of his experiences, I think, working with in the SARS outbreak in Singapore in 2003. David Heyman was sort of the architect of the response for the SARS outbreak in 2003, and so he'll give his perspectives for that. And I think, David, you just came back from meetings in Washington to discuss this, and so really kind of the latest update that we have. Rosalind Nego has been really one of the strengths of the school is the modeling work, and so she'll present what we're thinking in terms of different models and where this is going. I'll tell you a little bit about the response from the school and the UK Public Health Rapid Support Team. And then Martin Antonio at the MRC Gambia, who will join us online to tell us about the preparedness activities in West Africa. So that, I hope, will take 30 to 40 minutes, and then we'll have 20 minutes for discussion and questions afterwards. So thanks very much for coming, and I'll start it off with you, Martin.
So it's great to be here. Such a lot of attention, of course, just at the moment. So I'm just going to give a bit of a historical perspective, really, thinking about what happened in my experience of SARS when I was there in Singapore. So this is just a retrospective analysis of what happened in SARS in Singapore and across China and the rest of the world. And you can see there was a little outbreak in January, February, and then the main outbreak happened about April, with further epidemics in Hong Kong, Taiwan, Singapore, Vietnam, Canada. So my little role was in Singapore, where I played a component of that. I think, thinking about this, you can see there's an end to this epidemic. We recognized quite quickly on that it was a coronavirus. By a similar method to this time around, it's very distinctive by electron microscopy. But straight away we got down to sequencing it, and I was at the Genome Institute of Singapore, so we're very molecular orientated. We sequenced the genome. That led straight away to a diagnostic, which is also a similar diagnostic this time, and also a little bit of history. We could work out how the virus had come into Guangdong, China, gone out to Hong Kong, and then spread out from there across the other locations, including into Singapore. So in Singapore it arrived. This was our little modeling, thinking about where the cases might go in Singapore at that stage, and we were predicting an outbreak. There was a big response. This is the school children measuring their temperatures, waiting for the fever to go up. But of course, predominantly it was a hospital-mediated infection, so the hospital staff were at the center of this outbreak. But meanwhile, in the newspapers, you can see actually the newspaper in Singapore reporting very clearly the outbreak and where the transmissions were happening. We had these so-called super spreaders, which led to large numbers of cases after that. So it was in the news, it was a hot topic. In the laboratory, we're busy doing the research at that stage. We looked at in vitro models, and we're trying to understand the host response. Why was it such a severe disease? We found a nice response looking at interferon. And at the same time, we looked at publicly available drugs. And actually, interestingly, the interferon response drugs looked like they have a response that might be therapeutic. And in fact, we started clinical trials on this. But at that time it was coming to an end. The laboratory work actually led to another problem, is that we had in Singapore one case came out of our laboratory, so that was a laboratory acquired case of SARS. And we were able from the sequencing to identify exactly which tube the person had been infected from. Unfortunately, we had experience in containment and that didn't go any further. But there was a lot of panic around it, that re-emergence of SARS in Singapore. So if you think of the timeline at this time, 2003, this was an amazingly fast timeline. We started in Singapore from April, and by July we had the drug screening, we had the diagnostics, we had the whole process, and in fact we were a long way along the treatment process. So, but by then the containment process had worked. So SARS was brought under control. So we thought about therapeutics, but actually the containment was the most successful approach. And this is right up from the time that the is SARS similar to back coronaviruses, and maybe it might come back one day. So there's a whole family of SARS coronaviruses in bats, somewhat similar to SARS, and they probably have an extremely wide range of disease phenotypes. So what happened in next was that we had the next pandemic for us was influenza, H1N1. That came into worldwide prominence as out-of-season influenza, reported higher levels of deaths. This is in June 2009. The little red dot in Singapore was small, and then a week later it was large. We had an outbreak in Singapore. This is the work where we showed that probably the virus came into Singapore via a flight. This is the incidence of those people on the flight. So the whole flight was quarantined, trying to contain that outbreak. Interesting experience trying to quarantine everyone from a flight. I managed to get the positives from that and sequence them. It looked like the flight attendant had actually passed, not the first reporting case. So a little bit less symptomatic, but still transmissible. And actually that flight attendant could explain all of the transmissions across the plane, including across the business class, so it wasn't an aerosol transmission, it was a contact. And if you slept more and didn't meet your flight attendant, you were protected. That's a lesson, sleep well. So in Singapore, we were able to follow the guidelines. WHO already had a drug for flu. We were able to utilize that. We used it prophylactically, and that was very impressive. And we were able to show that curtailed the numbers very quickly. As soon as that started happening, I think we could show from our sequencing that quarantining didn't work. It came out of Singapore, out of the quarantine, and started spreading across Singapore. And at that point, the whole strategy changed. Singapore changes strategy, start thinking about who is at risk, who is most likely to get more severe disease. And there was a lot of informatics, commercial discussion about how you should be socially distancing. And there was a rapid outbreak of the disease across Singapore. So just some final thoughts. So SARS was transmissible only after symptoms onset, and that resulted in SARS being predominantly seen in hospitals where it's a bit easier to contain. So you had symptoms, you could be diagnosed, and then you could be contained, and that resulted in the containment of SARS. Whereas influenza, H1N1 was much more difficult, although there was a huge effort to do that containment. It wasn't worked. Prophylactic drugs were immediately available, and still we had problems containing that, and that ended up as a pandemic. But H1N1 turned out to actually be a relatively mild disease, still a problem, but not really as bad as we first thought from those outbreaks in Mexico. So that's my thoughts. That's the scenarios that I see from my experience in that. Thank you.
I think what we'll do is let all the speakers give their presentations, and then we'll put the panel together for questions. So over to you, David.
Thanks, Dan. I'm David Heyman, and I'm on the faculty here as well. And I've been involved in emerging infections since the first Ebola outbreak in 1976 when I was with your director at that site. So I've been at a lot of different outbreaks. And of course, the first thing that you want to do is do a risk assessment of what's happening. And to do that risk assessment, there are three things that you want to know. You want to know about the transmissibility, the means of transmission, and the best way to manage patients and prevent them from infecting others. That's the most important information early in a new and emerging infection. And let's dwell on them a little bit, because transmissibility, in general, there could be three outcomes. There could be transmissibility from a patient, an animal to a human, and no further transmission. Rabies, a good example. There could be transmission to humans and then human-to-human transmission, and the outbreak stops, but could in the future reappear. SARS is a good example of that. Ebola is a good example of that. Avian influenza, a good example. And then there's the third type of emergence, which emerges and becomes endemic. And of course, that's HIV, which emerged probably at the late 19th or early 20th century from an animal to a human, gradually mutated into the HIV viruses. So those are the transmissibility concerns you have at the start of an outbreak and at the start of this outbreak. The second you want to know is means of transmission. Is it close contact with body secretions, hands transferring it from patient to patient? Is it close face-to-face transmission with droplets, heavier than aerosol? Or is it aerosolization over a wider period of area of space and able to infect many, many more? So those are some of the questions in addition to what's working for patient risk management. Now, for patient management. WHO has been doing risk assessment since the very first day that they had a report on this outbreak. And early on in risk assessment, you use what information you have not only from the current outbreak, but from outbreaks that previously looked the same, which in this case was SARS and the MERS coronavirus. So taking all the factors of those two outbreaks plus the current outbreak into consideration, they did a risk assessment and they put out immediately precautionary measures. And as you know, precautionary measures are those measures which are the most severe. They're the ones that will stop any type of transmission, hopefully, and they're the ones that go out first based on what's known from previous similar diseases and what's known from the current disease. Now we're in the stage where more information is coming in from the current disease, and less important is SARS, as Martin just talked about, and MERS coronavirus. And so now the emphasis is on collecting information about the current outbreak. And that information is coming from three major sources. One is from the official reports in China. Two is from peer-reviewed publications that have been occurring in many different medical journals. And the third is from informal working groups that WHO has set up of clinicians working with patients, of epidemiologists at outbreak sites, and of the virologists. And those groups meet regularly by telephone, by virtual means, to share information, because sharing information is the best way and the only way you can get the information necessary to do a risk assessment. So WHO changes this risk assessment periodically, and we'll talk about the current risk assessment, but there's some other important issues in risk assessment as well, and one of those is modeling, and you'll hear about modeling later on today. Modeling takes the information necessary, and then that information, the information known rather, and that information is fit in to the models, and you'll hear about that as we go on. There's one risk with modeling, though, and that is that the press loves to seize on this as fact instead of as being used to help the epidemiologists and those dealing with the outbreak. And many times the press is way ahead of the evidence because they don't clearly understand what they're reporting. I thought it might be interesting just to take, do we have a couple more minutes? To talk a little bit about the emergency committees. The emergency committees are different than WHO's risk assessment. WHO's risk assessment is done by the GORN group, by a group that advises GORN, and by other advisory groups to the emergencies program. The emergency committee is specific for one thing: decreasing the spread of the international spread with minimum impact on travel and trade. So maximum security to minimize international spread with minimum interruption in travel and trade. The first EC, as you remembered, was divided on what they wanted to recommend, but they, in the end, felt they didn't have enough information in the risk assessment to be able to make any recommendations. So they waited for a week, and after that week, they had a second emergency committee. But before the emergency committee, the Director General convened two different groups by telephone. One group was the STAG, the STAG, Scientific Advisory Group for the Emergency Program, and one was just a group of experts from around the world. I participated in both of those calls, and the DG was listening very clearly to what was coming from many different sources. And when he had the emergency committee the next day, he had that information plus the information from the emergency committee, and he made his decision. And it's only the DG that decides on the emergency of international concern. He takes information, or she takes information from many different sources, puts it together. So where are we today? Well, today the thinking is that this outbreak occurred from not just one market, but from multiple entry sources, possibly the same animal or the same environmental factor, but many different sources, which appear now to have decreased or have hopefully decreased. So the genetics, by looking at genetics in various people, they can determine that this has come from probably many different sources, but still very stable virus, and it's considered a stable virus today as well. Also known is that in China there are 40,000 suspect cases, and 17,000 of them have been confirmed, and there are approximately 300 deaths. Well, deaths are always very serious in an outbreak, but they also lead to false interpretation, because when diseases get to a hospital, the case fatality rate, of course, is much greater than the case fatality rate if the denominator included asymptomatic and very mild cases, which appears to be what the majority of these infections are. So case fatality rate is being determined, mortality rates are being determined, but most important right now in WHO's risk assessment and in collecting the data are those 23 countries to which 151 cases are exported or occurring. Because those countries are outside of China, where there's a lot of panic and disorganization. They're in countries where the contacts are being closely followed up, some in Germany, where they're learning a lot already about transmissibility before signs and symptoms are clear. A whole series of studies around the world around these cases that have come into the 23 countries where there are importations. What's very important, though, is that many of these patients, at least Germany and others are finding out, many of these patients who appear asymptomatic have actually taken antipyretics because they felt like they had a cold or some other disease. So it's really not clear exactly yet what the transmissibility is. As Martin said, transmissibility was well after the onset of infections. It seems that this is more like some other infections which may be infectious early on, maybe a day or so before the onset of fever. About transmission, it's clear that it's face-to-face or in some way probably by droplets and also by close contact, because health workers are being infected. Initially, when China reported at the start, it appeared to be a point outbreak where health workers were not infected and where it was going to be easy to contain. But as reports came in, clearly health workers had been infected, and they're the part that transmits infection in hospitals and also expands epidemics into communities inadvertently to their families and others. So health workers are at great risk in all emerging infection outbreaks, as in this one. So I've tried to give you a brief update on where things stand today. Still a lot to be learned. WHO will be modifying its risk assessments periodically. The Emergency Committee has made some recommendations. They will meet again when the Director General feels he needs more advice, but at the maximum 3 months from the date of the first meeting, because it's required to meet every 3 months until they disband themselves. So that's a little bit about what's going on. And just remember, at the start of an epidemic, it's not what you know, it's what you don't know that is extremely important. And you've got to strive to get that information, as is being done now.
Hello, my name's Rosalind Dego. I'm one of the Deputy Directors of the Centre for Mathematical Modelling of Infectious Diseases here at London School. Briefly, why are we modelling this? So modelling aims to understand the transmission dynamics of this new pathogen and why we see cases when and where we do and how quickly we might expect more. So the overall aim is to understand transmission enough that we can make predictions, both for how many cases, where those might be, and fundamentally what interventions might work best to try and contain or mitigate this epidemic. And David brought up the key characteristics of the pathogen that are unknown, especially at the start of the epidemic or outbreak. And this is something that, that we need to translate not only these key characteristics as we come to know them, but also the uncertainty that we have in those characteristics into the models. So one thing that we're doing here at the Centre for Mathematical Modelling is that we are trying to be extremely transparent with all of the analyses that we're doing in real time. And so we have this public-facing website which has all of our projects, all of our papers, and all of our code, as well as putting our stuff onto preprint servers at the same time it's submitted. So this site is updated in real time. So that's something that we're trying to do to be transparent. And what I'm going to do is just go through a couple of the projects that we've done so far, literally looking at the website, to try and show you, the key public health questions that we're trying to answer with our models. So let's start here with this one. So David mentioned that this is a spillover, a zoonotic spillover. So that means that this was a virus that was circulating in animals and has moved into people. And the key question we wanted to ask with this piece of work, which is actually shown here, is early on in the epidemic, we see a rapid rise in the number of cases, and we wanted to try and ask the question, what size of initial spillover event, so how many people got it directly from the animal, is consistent with the early reproduction number that we saw. So the question is, if that spillover event is bigger, so you have, say, 200 people infected initially, then the reproduction number, so the average number of secondary cases that each infected person creates, is lower, because as you observe these cases, there's a lot, but if the initial event size was bigger, then that growth doesn't need to be as big. If it's a very small spillover event, then in order to see the number of cases that you have seen, then you would need to have more people infected for each case. So what this is doing, these kind of figures are extremely trendy at the moment, but what this is trying to show is the relationship between this reproduction number, the number of secondary cases you see for each infected person, and the spillover size here. So we'll just look at this one down here. And this is saying that if you think that there is a high number of spillovers, then the reproduction number can be lower than if you think there's a lower one. Then in order to recreate the early dynamics that we saw, you need a higher reproduction number. Okay, so that's one question. We're just going really fast. You can check all of these. There's papers online. We were also asked to what is the effectiveness of screening travelers who may arrive in a country? What is the effectiveness of screening those at catching people who may be infected? And so what you can see here, we have written a paper, but we also made this online tool, which allows you to set the travel duration over here. Can you see this okay? So this is how long your flight is. This over here is how good your exit screening. So that's if you get checked for symptoms of illness at the airport when you leave. Is same for entry screening, so when you land, and the proportion of cases that are asymptomatic. And then down here, we can change the natural history of the pathogen. So these are the key unknowns to say, for instance, after somebody is infected, how long does it take until they show symptoms? And after that, how long until they seek care? And you can change these percentages, and what this model will do is it will update the number of people detected either at entry. So the green is detected at exit screening, so they never get on the plane. The pink is people who get so ill on the plane that they they want to seek care. And the blue is people who are detected at entry screening. And this orange chunk here is the people who are not detected at entry screening. Okay, so even if you have perfect screening both at entry and exit, and you have some asymptomatics, it was here set on 17%, you can see that a huge chunk of infected people would not be detected at screening. And if you make the flight longer, for instance, then more people will become ill on the flight, but it doesn't make very much difference to the number that are not caught. So that's one question that we specifically were asked to answer about traveler screening. Is it effective? And there's other points about traveler screening, that it's extremely expensive, extremely disruptive, but we didn't go into that. We just said, can it catch cases? And then I'll just really briefly talk about the one more. We mentioned the reproduction number, and what we're doing in this model is saying, can we calculate the reproduction number, so the average number of secondary cases that each infected person creates, and can we measure that through time? So is there any evidence that that is changing? And so this particular model is a transmission model that fits both to the early epidemic in Wuhan itself, so that's this one, and it also fits to the exported cases to other countries. And what the reason for doing that is to say, what is the size of the epidemic that must be happening in Wuhan in order to explain the number of infected people that have left? And the red line here marks travel restrictions that started when when flights were stopped there. And so this panel here, I know there's a lot going on in this one, is the reproduction number. And so the dark blue line, you can see it okay, is fairly consistent, just around and just below 2, potentially a little bit lower here. But you can see one thing that we are obsessed with as modelers is uncertainty. How uncertain are we with the results? And that's what you can see here, this big envelope, to say we do not have enough data to support anything wider than this envelope. That's our 95. I think this is the 50%, and that's our median estimate. So it's a key point is to understand not only our estimates, but also our uncertainty. And as David also pointed out, if you put a confidence interval or a credible interval of number of cases that includes 150,000, that is the only thing the press will report. So you have to be careful but accurate in your conveying uncertainty. So other work is ongoing. I just talked about CMMID work, but there's groups all around the world that are doing similar kind of projects to try and understand what's going on with this epidemic, both using similar methods, other methods, and that's really the strength of the work that's coming out. Overall, we're aiming to use our models to answer key public health questions, and this will be updated in real time if you want to keep up to date. Thank you.
Thanks. So a little bit now about the response from the UK Public Health Rapid Support Team, and a little bit about that team first of all, so people may not be aware. So this was a team that was created about 3 years ago in the wake of the large West Africa Ebola outbreak for 3 things. So we respond to outbreaks. We're the primary UK entity for the response and coordination for outbreaks, but also importantly for research and for capacity building. And so if you will, the idea is that we go and try to help put out the fire, but also we try to ask the question, what started the fire? What are the gaps in knowledge? And then with partners on the ground, work to answer those questions. And then the last step, of course, is to work on the capacity building stage, and so that the fire doesn't start again. So it's a collaboration between, it's co-led by the London School and Public Health England. So we have some of the people who are based at Public Health England, some based at London School. We also have collaborative agreements with Oxford for patient-oriented research. We have Olivier Lepoulin as our Deputy Director for Operations, and Ada Seal, the Deputy Director for research here, and many other members that are around the audience. And so I think I'll volunteer them. Feel free to track them down if you have questions. But a little bit now about kind of my take on this, and then really what our response has been. We often respond to outbreaks of Ebola. I've been very engaged in the Ebola outbreak in DRC and Lhasa and other things. But I'll have people ask me, what's the scariest outbreak that you ever responded to, or what was the scariest event? And for me, it was that H1N1 outbreak in the pandemic in 2009. And the reason that I say that is that because we saw very, very early on where that started in northern Mexico and then crept up gradually into Southern California in the United States, and then crept to different places in the States and overseas. And so even though we saw that very, very early on, we were really not successful at all in impeding transmission. And so that, I think, is a very scary event. And then, as Martin and David mentioned, we were just lucky because that turned out to be not a particularly virulent virus. Nevertheless, when we talk about outbreaks and you say, well, there's a case fatality of 0.1%, if you do the math and say, if we have 500 million people who are infected, the absolute mortality is pretty much even with a low number. So it's still a very important event. And then there's still important events in terms of the economic impact, social impact, many other things that go on. So that was, I think, in some ways, one of the most sobering events that have happened. And then SARS, of course, and Martin contrasted this. This was a little bit of a different thing with about a 10% case fatality. So if you could choose which virus you wanted to get infected with, you would choose H1N1 over SARS coronavirus, but you'd be more likely to get sick with SARS. You'd be more likely to get H1N1, but more likely to get sick with SARS coronavirus. And so we saw that. I spent a lot of time in Vietnam during the SARS coronavirus outbreak and trying to limit transmission there. So I think really, the big debate is whether is this more like H1N1 or is this more like SARS coronavirus. So far, it seems maybe to be a little bit in between. We have a case fatality that's 2%, 3%. I think that will go down. It's, as David mentioned, it always looks high in the beginning, and then when you start to understand the person who has a little bit of a cough and stays home for a few days because they don't really feel particularly sick, never gets into the denominator, and so ultimately our case fatality rates often go down. So we're trying to see basically which animal this is. The real question right now, I think, and again it was mentioned, is really not so much what's happening in China, and that doesn't mean that that's not extremely important, but we have limited ability to really impact that right now, and the cat is kind of out of the bag in many places in China. The question is, does the cat get out of the bag in the other places? And so that's really of our opportunity right now. Can we keep the cat in the bag? And what I mean by that is in the US, in the UK, but especially in low and middle income countries, and we're particularly interested in what's happening in sub-Saharan Africa, can we prevent widespread transmission in those countries? So that's really the focus. And what I want to be clear that I don't mean that China doesn't matter, that it's not important, that we don't have sympathy for people who are sick there, but we have relatively little opportunity to really impact on what's happening in China right now. And also there's capacity in China. And so we're really trying to see what happens next and whether this gets really to be widespread transmission in other places. And so to just then encapsulate some of the activities from the UK Public Health Rapid Support Team, or to not have to say that long name all the time, we say the RST. So the RST, we've been quite active. Well, first of all, the first thing sometimes people say, we want to film your team doing things, and the first statement is always, it's not that interesting filming people on the telephone because you do a lot of teleconferences, and so I think Olivier spent the last 24 hours straight on the telephone, and Anna as well, and so there's just a lot of communication, but communication is extremely important. And so GORN, which is the Global Outbreak Alert and Response Network that works closely with WHO, put out a call for support last week. It's not support going to China, it's support going to the regional office in Manila, so the Western Pacific Regional Office of WHO. And so we have offered support, epidemiologists and IPC experts to go there. This is, again, to really support the regional efforts in that area. They may stay there. They may ultimately end up being deployed to other places, depending upon what's happening. So that'll be coordinated out of that office in Manila. There's one case right now, more than one, or just one in the Philippines? One, I think. So it's not really so much the response in the Philippines. Obviously, that's important, but it's a regional approach, and we'll see what goes on from there. We've also gotten a request from Nigeria CDC, and so collaborators, we work very closely with them on many other projects to try to help with diagnostic support in Nigeria. There are a lot of things. It's not so simple as just having people who can get the reagents. It's, of course, making sure that we have the right quality control. So you can imagine the consequences of a false positive or a false negative in a country that's not yet reported a case are fairly significant, right? And so we need to try to help countries to make sure that that can be done correctly. So we've been working with them. It's not all in our hands. There are other issues about reagents and quality control, and working with WHO to put this forward and to really build diagnostic support across different places in sub-Saharan Africa. Doesn't mean that we would have diagnostic support, and we will never have. It's not every hospital that is going to have this, but we need to have some reference centers, and we need to know what the referral mechanisms, when you have a suspected case, where they would go. Our team in Oxford, led by Peter Horby, has been working on, they have a lot of expertise in clinical trials, so they've been putting together tools for clinical trials and case report forms and different things that we would use. And there are some clinical trials that are ongoing in China, other clinical trials that are contemplated, and so that's an extremely important aspect. I'll come back to it in just a minute, but of course the research part of it, David mentioned the things that you don't know, so it's extremely important to try to use the opportunity when these things happen to do research, even though it's extremely difficult. But we're involved with research, for example, in Ebola in Democratic Republic of the Congo, and people say, that must be really hard to do, and why would you do that? And I say, it is really hard to do, but what's the choice, right? And we don't really have the choice to say, we're just going to wait for the next Ebola outbreak that happens in a nice, calm, comfortable place, and then we'll do the research there. We have to really take the opportunity to do the research when these things happen, and that includes with understanding more about coronaviruses during this epidemic, or if it's not a pandemic, it's doing a good job at imitating one. We'll see where that goes. But so we've been involved in the clinical development of clinical tools, and then developing or providing strategic supports to WHO. And I mentioned we're on the phone or in Geneva, and really very active in kind of thinking through things with them, and not only as a response organization, but also in the strategic development and how should we be responding. Also, especially in the last 48 hours, some of you may be aware of Africa CDC, so a new entity that was created based in Addis Ababa in Ethiopia, led by John Nkengasong, a very capable leader. And so there's been a lot of discussions in how we support Africa CDC, and we're looking into that both in terms of training and capacity for detection, but also with research. And so the real focus of research and what we're interested in right now is some of the questions about dynamics of transmission, because they really inform the public health, and they really inform these models. And Raz mentioned, the assumptions that you have to make. And you notice that she did not stand up and say, here's what's going to happen. And the reason that she won't say, here's what's going to happen is, one, because she's smart, but two, because there's all these assumptions. And so if they weren't assumptions, if we had data, then you're a little bit more comfortable in saying, okay, here's what's going to happen. But we really have to do the research to understand that. And so a lot of discussions, and it takes time to put these things together. It's not something that we can jump into right away, but we do have a dedicated team for that, and with the RST, and so we're working on that. So I think I will stop there. And we'll go to Martin Antonio, if all works for the remote connection. Thank you, Daniel.
So, my name is Martin Antonio. I'm currently Professor of Molecular Microbiology and Global Health at the London School of Hygiene and Tropical Medicine, but I'm based full-time in the Gambia. So I spend most of my time in the Gambia and also travel a lot among the African sub-region. So my lab is the MRC, the Gambia lab is a WHO collaborating center for new vaccine surveillance. We are also the West African Health Organization Center of Excellence for conducting research in 7 countries in the sub-region. So this gives us really a very good opportunity to work with regional bodies such as the African CDC in order to control this coronavirus outbreak. Just a little bit of my past. Just like Dan, in previous years, I've worked in Nigeria and Ghana. In Nigeria in 2017 to combat the outbreak of meningitis that occurred in the north, and also in Ghana in the central region. So, working with WHO, we have an experience in working with outbreak situations in Africa. And you may ask that, I'm sure you all know, that the healthcare system in Africa is fairly weak during outbreaks like that. And this is due to leadership and governance problem, as well as weak health system. But I'm very pleased to say that after the Ebola outbreak, a lot of the systems in Africa has been strengthened, and some of us, we feel that Africa is now well placed to fight this coronavirus infection. And so, how do we come in? There are two aspects in which African CDC has asked my lab to help. The first is that the African CDC is organizing a training in Senegal, in Dakar, from the 6th to the 8th of February. And they're providing, if you like, pan-genome primers, which is targeted to the region of interest to be amplified. And this training is going to occur, and then kits will be distributed to the various labs in Africa. And then the second aspect, which I'm really keen and we're doing in our lab, is to use what we call the next generation whole genome sequencing in order to sequence the viral particle should it arrive in Africa. And I have to mention that so far, we've not seen any of the confirmed cases in Africa, though we've had rumor in Cote d'Ivoire, in Kenya, and also in Egypt. But so far as I'm aware, this has not been confirmed. And they're really keen to use this new technology. And I have to mention that we had a very few centers regionally to have the capacity to perform whole genome sequencing, including using Minion. And we're hoping to do that in order to determine the genome sequence of the pathogen that is circulating, of course, we want to work out the similarities and differences with other coronaviruses that has been described in the past, and those that are emerging now. And I believe that it's really important that this is done in Africa. Part of the reason is that to get ethical approval to send samples abroad has been really difficult, and it's also costly. And so this is an opportunity for us to work quickly in Africa to diagnose the infection and also to understand the outbreak pathogens. And then the analysis also needs to be done here. And then lastly, a lot of work that we do also lead to capacity building. So when we were in Nigeria and Ghana, during the various meningitis outbreak, we spent a lot of time building capacity within the health system in the sub-region. And again, this is really important that we are able to do that. So thank you very much, and happy to take more questions. Thank you.
Great, thank you, Martin. Maybe if we can have all our speakers come up, and we'll entertain questions from the audience. Yeah, floor is open. Questions, thoughts?
So during an outbreak, how do you make sure that people around the world have the right capacity to diagnose a virus? And how do you go about making sure they're diagnosing it the right way? And what is the right way to diagnose it?
Yeah. I don't know. Martin, you want to?
Just a quick comment on that. So I think the other Martin was explaining that for Africa. I think there's two components to that. One is the technical side, to make sure you've got your controls, standards, primers, and that has to be up and running and ready in all of the places where you're likely to be doing the diagnostic testing. And then there's the kind of standards and clinical side to say what samples and how that process is done as well. So all of that has to be kind of explained and worked out by discussion, essentially, at this early stage, because nobody's got experience of doing that yet.
And, if nobody shares the virus, then nobody can develop the tests. And that sometimes is a problem, although for this outbreak it wasn't. The virus was shared early on with many laboratories, Center for Disease Control in the US, Public Health England. It was shared with the Robert Koch Institute, with Japanese laboratories, and all these laboratories at no cost to the world as a public good develop diagnostic components that can then be provided to countries that don't have that capacity. And there's actually a workshop in Dakar next week conducted by John Kengasong from the Africa CDC, where all the tests that have been given to African countries will be looked at, and there will be a training course on how to use them. So fortunately, there's today in the world a good public will. It costs industrialized countries money, but they do it all the same to help developing countries and those that can't have the capacity develop the diagnostics that they need to better do the job. Do you want to say something?
I don't need the mic because I'm here, but I'll maybe just add, first of all, it should be said that there's been incredible progress in Africa and sub-Saharan Africa in the last 20 years in terms of public health and diagnostics, and so that should be mentioned. I do think that we have particular concern for Africa being a vulnerable area, but it's changed drastically from what it was 20 years ago, where frankly at that time I worked some with U.S. CDC. You may notice my accent's a little bit different than many in the room, but speaking proper English. But at that time we pretty much, it was a given for outbreaks. We just packed up everything and we sent it back to Atlanta, where CDC was based, and that was kind of assumed to be the normal thing. And now, these days there's a lot of places where the capacity is there, and it's just now a matter of kind of some strategic guidance and then, of course, reagent support to get this into place in the quality control. I'll also mention that, we hope it matters, because if you think there's really two reasons why you want to diagnose a particular individual. You want to diagnose them if there's a specific treatment. So if you want to know, okay, do we give this person this treatment? Right now we don't have a specific treatment, and we think that most of the cases are mild. And then if we need to understand the dynamics of transmission, and that's usually in the early cases, right? So if we had one case, a suspected case in London, for example, we'd really want to know, is that a suspected case or not, so that we can try to stem onward transmission. Once you're at the thousands or 10,000th case, it doesn't really matter anymore, right? Because we don't have a treatment right now, and then you're not going to do anything. You're not going to isolate 10,000 cases, and so it's really key to get this in place right now when it can make a difference. Other questions? Please. Yeah. Oops. Yeah, that's fine. We'll get to you in just a minute. Yeah.
Looking at the model on effectiveness of airport screening, I see a number of cases were missed from the model you presented. Now, what advice can you give as alternative approach so that we don't have disruption of international travels and trade, but also making sure that countries are protected?
Generally, I don't give too much advice, but what I would say there is that the reason that you see that is that the people fly during their incubation period, so they're not yet infectious, and that's why you see that. But what's done, I believe, is that travelers are given information so that if they do develop symptoms, then they're encouraged to report it and seek care if needed. And so those people, if they develop symptoms and promptly report them, and then you can prevent onward transmission. So in general, this model does not give advice on what to do, but just to say that the policies that have been used are to try and prevent onward transmission, even if people do arrive who are infected. Do you want to add to that?
I would just add, though, that many countries do decide to do airport screening for various reasons, and there are some benefits that occur from them as well. You identify some patients early, so they get earlier management. You get an opportunity to talk to all people coming in about the signs and symptoms of the disease, and also you can give them a paper with information about those signs and symptoms and where they should report should they develop a fever. understanding that they will, many of them be in the incubation period. So though it's sometimes not the decision an epidemiologist would make, it is a political decision, and as an epidemiologist, we need to make sure that we get out of it what we can get from it as well. And so there are some benefits, and we need to push on those benefits, as well as just say it should not be done.
Yeah. Well, why don't we go here?
Thank you very much. My name's Yodi Alakaja, and I'm sometimes from Nigeria. But my main concern, and I don't know whether it's a question more as a comment and perhaps getting some insight, is the fact that it's never just about the epidemiology or the science. It's never just about the modelling. And whilst we're all being terribly politically correct and not wanting to offend anybody by saying that health systems are weak in Africa, or that we can potentially diagnose, as the other Martin, I'll refer to him in your terms, has said in MRC, what happens when we do find those cases? Because in a country, I mean, I dread to think what happens when it hits Lagos, Nigeria, or Bole Airport in Addis Ababa. I think we're skirting around those issues, and I think we need to have some serious discussions about the practicalities of, as you just said, the politics versus the epidemiology. What happens in a health centre or in a hospital where there are no oxygen canisters? My father passed away early last year, in UCH, which used to be the premier hospital in Ibadan, Nigeria. And at the time, I'm told there were 2 mobile oxygen units in the entire hospital. This was for a high-profile person who they would have been doing everything to try to save. So what happens when your regular person off the street, or hundreds of them, or thousands of them, are rushing into healthcare facilities? How do we begin to address these issues? How do we advise policymakers and policy leaders? How do we address the political dimensions of these crises? How do we address the fact that China's Belt and Road and those discussions are really affecting at the moment the way Africa deals with it? So whilst the modelling is great, the epidemiology, I'm an alum of this school, so I came here and I learned all of this here. But when I went out into the big wide world, I realised that the reality of, for me, last year trying to stop cholera, or 2 years ago, in the northeast of Nigeria, meant that there were some very hard discussions and decisions to be made. How do we do that? What do we do when this thing hits Africa? Thanks.
I think it's not only Africa, it's any country with a weak health system where this is important. And about 4 years ago, we got together a group of people to write a series of essays in the Lancet on health security and the broader definition. You know, every industrialized country and every country now in the world is thinking about health security, but they're thinking about it in the wrong way. They're thinking about it as a protect me against those diseases that might come in. But there's a whole other part, that's a collective security, collect my populations. But there's a whole other part to health security, and that's individual health security. Make sure that the goods are available in the centers where they're needed so that people can be managed. And you're right, in the Ebola outbreak, health systems collapsed. More children died from malaria than from Ebola because they couldn't access health care. That's a proven fact. And these are the things that we have to do as public health workers, convince those who allocate the resources that health security is not just protect me, it's protect everyone. And by protecting everyone, you protect the collective and the individual. And until we can get that message through to the politicians, we're not going to succeed in getting funding into the universal health coverage that's required. Dan, Mike.
Yeah, I was going to add, you brought it up. I think, one of the things, it's not easy, and so I don't think any of us can profess to have, the answer, but I think that we need to look at universal health coverage really as a health security issue, right? And that's one of the things that really needs to be promoted. We've thought about this, but we haven't gotten the answer. And with our rapid support team, we do recognize that we go, for example, for an Ebola outbreak, and we're passing the kid that's dying of measles or malaria to find the kid that's dying of Ebola. And it's not because we're bad people, but we also don't have the bandwidth to do everything. And then, of course, This outbreak, perhaps in China, is a little bit different, but in many of the places where outbreaks happen, they happen on the backs of complex humanitarian disasters. Of course, they're happening precisely in the place where the health system's the weakest, and so now you have this challenge of not only the pathogens that's circulating, but of course the absolute worst infrastructure to try to deal with it, and trying to deal with it all of it at the same time is extremely challenging. But we do need to think beyond it, and those of you who've heard me, if you're students here and you've heard me talk, you'll always hear that I mention something about health and human rights, because we can't think that biomedical innovation really is the only key here. If we look, for example, that the outbreaks that our group has responded to, about half of them have been vaccine preventable illnesses, and so we have the tool, right? It's just a question about getting the right tool to the right people. So I think we need to remember that it's not just about the biomedical innovation in our research and what we do as healthcare workers. That's great, but I think advocacy is equally important. Other questions?
I'm actually just going to read a couple questions that we have from our online viewers, because there's quite a number of them from around the world. So the first one's from Kiara, and Kiara wants to know if the traveler screening has been shown to be effective so far, if you could tell that from your modeling study. And just the second question is, Sedalia wants to know, I have seen the recommendations for healthcare providers from WHO and PH, and they're very detailed. However, should there not be more emphasis in practical training for those healthcare professionals?
So for the first one, so our model is just theoretical, we're not fitting to any data, but there have been cases detected at airports so far. So as David said, it can work. In the model it can catch some cases, and so it's, but we don't predict that. What was the second question?
Training for healthcare providers?
Yeah, should not more emphasis be placed on training?
Training for healthcare providers has been always very difficult in infection prevention and control. From the first outbreak of Ebola, it was known what causes Ebola outbreaks. It's amplification of transmission by health workers who get infected and inadvertently infect patients, their families, and the communities. Every outbreak of Ebola that's known has begun in that manner. It gets into a health system and is amplified in transmission. Otherwise, it goes, until it gets to a health facility, it goes in a small chain of transmission. How do you stop these outbreaks from amplifying, whether it's Ebola or coronavirus? That's the job of the 21st public health, really, to understand how a health facility with no fuel, so they can't boil or sterilize equipment, with very few injectable equipment. They have disposables that they use over because they can't find any from the government. It's a matter of governments getting on board, engaging, and health facilities understanding. So it's a very complex issue, but if a government engages in it and wants to make sure that infection control occurs in hospitals, there are ways of doing it. And so the top has to come from the top of the government. And many times governments blame it on their health workers when it's really the government that isn't investing enough in the training of their health workers.
Question there?
Just thinking about other preventative measures, are there any hopes for vaccines?
So there's a lot of emphasis and funds that are being put into vaccines right now. You know, there was a lot that were put into SARS as well in 2003, and then SARS, the outbreak ended. The only transmission after the end of the outbreak were a few laboratory accidents, and then after that we haven't seen any SARS in the world since then. And so public health and research being relatively fickle, then I think most of that kind of came to a stop in terms of developing coronavirus vaccines. And so now we're seeing this emerge, and you know, some of this is the bigger question of the pendulum swing of we do it every time, quite frankly, and say, okay, now something's happening, and let's spend millions or billions of pounds because something's happening. And if we just spent, you know, hundreds of thousands or perhaps less millions of pounds in the meantime, we could avoid the emergency and obviously the cost, but also the loss of life and the morbidity. But so there are talk about vaccines that are being developed now, but I think Probably the technology is the less challenging part of that. In terms of developing the product, the more challenging part is just rapidly going through some of the clinical trials and phases that are required to get through to actually having a licensed product. And then there are other ethical and social questions. Who gets that vaccine if you only produce a limited amount? Will the UK or the US keep all the vaccine to vaccinate everybody in their country, or will it actually get sent to other countries perhaps that are more vulnerable? So a lot of questions with that. I don't know if David or Martin, you have anything to add.
I think, vaccines is the challenge of actually making a vaccine, and obviously there are other coronaviruses which commonly infect humans, which we don't have a vaccine towards. And of course, there's a lot of vaccine-preventable diseases out there, which means that even if you have a vaccine, you may not get to everyone, as mentioned. I think there's also a time frame here. You can't rush into. You've got to do clinical trials. You've got to make it. There's a whole process to that. Of course, if the disease is around in a year's time, maybe there'll be continued interest. Maybe.
Let me come actually to follow on with that with Martin Antonio. So how do you feel, how rapidly could clinical trials be done through your unit in Gambia?
Sorry, I'm trying to switch it up. Yeah, so how quickly can clinical trials be done in Gambia? It depends on when the protocol is submitted for ethical approval. I think this is one of the stumbling blocks, but due to training through EDCTP, the ethics committee recognizes the importance of outbreak, not only in the Gambia, but also in the sub-region. So they are really amenable to clinical trial. So as soon as we can get a protocol for them to approve, of course, London School will also have to approve the protocol, then we can actually do it.
Okay, thank you. Yep.
And let me just say that outbreaks can be stopped mostly without vaccines if they're transmitted in the way that we believe this coronavirus is transmitted. So never forget the basic epidemiology of isolation of patients, tracing their contacts, identifying new patients, and making sure that you follow up on those contacts. If they have a fever, get them tested and isolated. Basic epidemiology can stop many outbreaks. It could have stopped smallpox, which had the same transmission rates as SARS. It could have done a lot of other diseases. So don't let your government say, we're waiting for the vaccine. Get out there and stop it now.
I think there's a question there. Yeah, please.
I would just like to ask you guys your view on the current intervention strategies that's being implemented by the Chinese government, including locking down the entire city and sort of putting the barriers to isolate the city in order to prevent further transmission. Because from my background of a public mental health kind of view, it's these strategies might pose a lot of stress on the in fact people who are in the city and potentially susceptible to the disease. And I would also like to ask you guys to how to manage these kind of mental health illness potential during the course of this outbreak.
That's a tough one, and I don't know the answer. You brought up some of the aspects. Of course, this comes up in almost every outbreak, actually, some degree, even large outbreaks, small outbreaks, some idea of should we quarantine people. It's not, or should we limit travel. It's not that there's never an argument for it. The challenge for it, one of the big challenges, is that what we ideally want with any outbreak is we want people who think they might have a particular disease to come to recognition, right? So if you think you have the 2019 novel coronavirus, or you think you have Ebola, or whatever it may be, what we want is that person to come to a healthcare center, or at least notify a healthcare provider and say, I think I have this disease. And so then we can say, okay, this is a suspected case. Let's test them. Let's get them the care that they need, and which includes isolation in these particular cases. And so, that's really what we ideally want to happen. once we start to put in negative consequences to being recognized, then of course, we all can intuitively think about, what would you do if people said in order to come through the front door of the London school, you have to, or you can't come through the front door of the London school to your classes unless you had this or that. Then, of course, if you have a little bit of a cough or a little bit of a fever or whatever, you say, I'm sure that's not that disease they're looking for. Let me hide that and come on in anyways. And so it creates that challenge. And then you mentioned also the mental health issues that can come from that. And then practical things. It's very easy for people, even in short terms. I don't think it's happening here in the UK, but you can say isolate people or put them in quarantine for 14 days. But, just think about it. If I say you're in quarantine for 14 days, the first thing you might say, this is great. I have great Wi-Fi at home, and so I'm just going to catch up on things and, I'll do some binge watching of different series that I want to see. But, how do you get your food, right? And what about the interaction with family and what about your other obligations? And so it's not a simple thing to put in place. And then sometimes when it even gets beyond that, when your kids can't go to school, so there are very significant consequences. So I'm not sure what the right answer is, but I think that we need to weigh the options in a sophisticated way, taking into account the potential advantage of quarantine and travel restriction, but also the disadvantages.
And I would add to that, from a modelling point of view, the time that some of these interventions were put in place is not that long ago. And if we have the incubation period, time to reporting, whatnot, it's only about now that we would start to see if these very, very major interventions have had any impact on the reproduction number. So that's right now, it's from a modelling point of view, it's not actually really possible to answer the question, what did they do? But these kind of analyses will be coming out in probably the next week.
And I might add that sometimes things such as this offer a false sense of security, and then you take your eyes off what's really happening. So I think in a case like this, if China has set up a new intervention which has never been tested before, it's an obligation that they also evaluate it and that they publish that evaluation and show whether or not it was effective. And there may be some parts that are effective. Perhaps slowing down travel in airports, international airports, has been in some way effective and maybe could be shown. But I think it's whenever you set up an intervention like this, if you don't have a system to monitor whether or not it's effective, you're not a good public health worker.
Yep, please there, I guess, was next to 3 in that row.
Hi, just touching on the case fatality rates. I was looking at the little map that Johns Hopkins University set up, and it showed that about over 90% of the deaths were in the Hubei province, while I think the total case is now around 60%. And I was wondering, do you think that's something with underreporting, or is it something that's been seen before, that where the epicenter of the epidemic, the case fatality rates were higher? Was that something that was seen in SARS as well? Your thoughts?
So the case fatality rate is a very difficult number to estimate, and of course at the start not many people have diagnostics. You're only looking at those sick people that come in, and there's kind of a complicated way of understanding that until we start seeing how many mild people that don't turn up at the clinic that still have the disease, and looking at that, then we start to understand. If you only have a limited setup of diagnostics, then you're only going to look at those most serious cases. So it's very hard at the start to really work out the case fatality rate. And so this is the beginning of it, and therefore it looks high, but the chances are that, as mentioned earlier, those numbers are going to go down.
Yeah, I would just add to that early on the case definition included pneumonia. So of course you were only finding the seriously ill patients. Now it's very difficult to decide what the real case definition is because it's such a mild disease in many people. So gradually they'll refine the case definition.
Okay.
Yeah, and I'd also add there's just timing, because that epidemic started first, so then you'll get the deaths first, and then, yeah, just.
And numbers, of course. So if we're seeing a 1 or 2% case fatality by provinces where most of the cases are, and so
Exactly.
that's going to be where most of the deaths are. But think we'll take just a few last questions. This row seems to be a question row, so why don't we finish off this row, and then I think we'll let people go and study or relax or whatever they need to do. Please.
Okay, thank you very much. I'm from Afghanistan, and my question is just, I know the Afghanistan and Pakistan, the health system, these are unfortunately the weakest in the world, the health system of the both country, and also we also have border with China. And I was just following today the health progress. So what we are doing in Afghanistan, we are only doing clinical assessment, like clinical screening, and we don't have, the diagnostic facility there. Do you think only the clinical screening, just to ask people, which kind of sign and symptom you have will be enough, or you have any other specific kind of recommendation for these two countries which have long borders, with China, and also specifically also they have many people are going and also coming specifically from Wuhan as well. Thank you.
Well, I can start out at least. So very, very difficult to diagnose a patient on clinical grounds alone. And, these are always the challenges, whether it's this coronavirus or Ebola. If you take especially the early phase clinical symptoms, even if you're the best clinician in the world, to distinguish the person who has one of these diseases is very, very difficult from other much more common diseases. So that's really a challenge that we have. And then the question that is how long will the epi background really help us? So initially we said, okay, initially we said the connection was the seafood market, right? So if you didn't have a connection with the seafood market, we didn't have to worry about it. Then it was, okay, it's Wuhan. So if you didn't have a connection with Wuhan, that you didn't have to worry about it. Now we say if the connection's China, so if anywhere, so then the question is, how far does that go, right? It's relatively easy when you're outside those places, if you have those very clear epi indicators, when you can say, okay, you weren't in China, you weren't at the seafood market, you weren't from Wuhan, and so we think that person's very, very low risk. If you start to have transmission that is very widespread, then you lose those epi clues, and then it gets extremely difficult. And the only way really to diagnose these is through laboratory diagnostics. You will not be able to routinely do it through clinical, just clinical observation. So that's really where we hope not to go, where we have that situation, but it's very challenging. And then of course the challenge, of course, is that since the case definitions are very broad, if you go to any hospital, you will say, well, I have 1,000 suspected cases of novel coronavirus or whatever it may be that day, and you can't really handle that. And we're seeing that in places in China, at least from the reports of 5,000 samples a day that are coming in, and laboratories can't keep up with that. And of course, we have no capacity in most places to isolate 5,000 people or 1,000 people every day. So we hope not to get to that, but that's really the challenge. Please.
Thank you very much. I'm Kazuki from Japan, who have a very great concern for the regional health security in Asia region. I have two brief questions. The first question is the reproduction number during the pre-symptomatic period, because some cases reported from Japan or Germany recorded as the cases without any symptoms. How do you evaluate with the pre-symptomatic reproduction number? The second one is the immigration policy, immigration or quarantine policy, the difference between each country. For example, the United States or Australia or Mongolia, even the North Korea has enforcing the strict policy for entering some Chinese to their east country. On the contrary, some Asian country like Hong Kong or it's a political, but anyway, Hong Kong or Taiwan or in somewhat way Japan is enforcing a bit milder policy for immigration. How do you evaluate, or how will you predict the outcome for containing the outbreak? Thank you.
So as far as asymptomatic transmission or transmission before symptoms occur, so what we can do, depending on how you're estimating the reproduction number, you can put, if you're using a compartmental model, so susceptible, exposed, infected, recovered, you can put in another compartment for showing symptoms or not, and you can vary how much you believe transmission. And ultimately, if you're trying to make estimations about the reproduction number, you want to fit your model to data. So you want to say what parameters of this model are match the observed epidemic that we've seen. And it might be actually that a variety of parameter sets do. So what you can do is you can include that in your model and then make estimation based on data to try and understand if there is symptomatic transmission, how much and what effect it's having on your reproduction number. Do you want to answer on the regional screen?
In the policy, quarantine policy, the difference of quarantine policy between countries, like Singapore or UK, US has a strict policy compared to other countries.
Countries are sovereign in what they decide, and they decide on their own risk assessment. And so the UK or Japan takes many sources of information, including WHO, including the Emergency Committee recommendations, but they apply them to their own risk assessment. So whatever a country does is decided by what their own risk assessment tells them. Private sector is a little bit different, and some governments, because there's also a consideration of insurance. Will insurance pay if my workers go there or if my workers are there? Will the...
Hello.
Put him on, put him on.
That's great.
I can't compete with that. I can't compete. I won't compete.
So, I don't think we can beat that. So, I think thanks everyone for coming. We'll try to. I'm sure the director will be putting out periodic updates for things going on in the school, and if in time we need to have another session to give you broader updates, we're happy to do that. So thanks very much for spending your evening with us, and have a good night. Thanks, Martin. Thank you.
Thank you.